if I do this.
Good afternoon, network. I'll be starting shortly. Kindly use the link in the chat box that will be posted to register your attendance. Thank you for joining. I can see we have Chisha Priscilla. Thank you for logging in. Thank you, Dr. Mbambo. Thank you, Dr. Kankasa. Dr. Singini, thank you very much. I can see we have Jacob Mudenda. Thank you too for logging in. Okay, so good afternoon, network. I welcome you to this week's tele-echo session. I'm Dr. Lungwebungu from Chilenje. Today we have the hepatitis team that will take us through the session. We have Dr. Mike Vinikoor, who's going to take us to the didactic presentation. We have Dr. Mugala, who will read our case scenarios. We have a team of experts. We have Dr. Hachambwa, we have Dr. Agren Wemba, Dr. Brighton Sokolo, and Dr. Edford Sinkala. We also have our manager, Kunda, to coordinate the session, and will be assisted by Mr. Chatonda and Mr. Kote for IT. So before we go into today's discussion, we just have a quick recap of last week. In our provincial sub-hub teams, we did look at transitioning patients failing first line to TLD. We looked at a number of studies, the NADIA study and our very own Vicent study done here at UTH, where we saw good suppression rates on those that were put on DTG-based regimens, even if their backbone was tenofovir, efavirenz, and lamivudine-based regimen. So for today, we'll be having a discussion around hepatitis B testing and interpretation of results. So I'll quickly hand over to Dr. Mike to take us through the didactic presentation. Please use the link that will be posted in the chat box to register your attendance. Thank you.
Should I start over? Okay, thank you very much. So this afternoon we have 4 learning objectives. We can go to the next slide, please. Number 1, learn how to interpret the different hepatitis B tests. Number 2, recognize the limitations of a rapid hepatitis B test. Number 3, identify some key populations to be tested for HBV. And number 4, recognize when to test a person living with HIV for hepatitis B. Next slide, please. So the first key population for hepatitis B testing we're going to talk about are blood donors. And I'll hand over to Dr. Mugala for the case.
So in our first case scenario, we have a 24-year-old woman who's a regular blood donor, and she has recently donated, and she receives a phone call from someone at the blood bank telling her to come for her results. So the next day she meets a counselor at the blood bank who tells her that a hepatitis B surface antigen test was positive, and she's given a printout of her results. So the counselor doesn't provide much more information than that about hepatitis, but instead refers her to OPD. So she's scared and decides to retest for hepatitis B virus. She goes to a private lab and requests a hepatitis test, and the results are as follows. Hepatitis B surface antigen was negative, and hepatitis B core antibody was positive.
So the first point we wanted to make this afternoon is that the blood bank is actually providing the most amount of hepatitis B tests in the country. And so they're also likely to find, and they're finding a lot of cases of hepatitis B. And so actually in Zambia, a lot of what we learn about hepatitis B comes from blood donors. You can see in this map that hepatitis B is not evenly distributed, but the prevalence appears to be higher in Northern Province, Northwest, and Luapula Province and Western Province. And it happens to be lower in Lusaka Province compared to others. Next slide, please. To understand the results of HBV tests, you need to understand the basics of the hepatitis B virus life cycle and the host immune response to it. So I'm just going to briefly go through this, which you might find interesting. So hepatitis B, represented by the small orangish circle, infects a liver cell inside the liver. And it uses that liver cell to reproduce itself. When it reproduces, the hepatitis B virus produces different types of RNAs. Some of them make daughter viruses, which is represented by the cluster of orange circles. But the virus also makes RNAs that just produce the surface antigen test. And so in the bloodstream of a person with hepatitis B, you find viruses, and then you find also the surface antigen protein. On the far right, this is the immune system represented by police. So the immune system recognizes the presence of the virus and the surface antigen, and it creates an immune response. It targets several different parts of the virus. So for example, the core antibodies are produced. This is the immune system responding to the core antigen on the virus and producing an antibody called the core antibody. And secondly, it produces the surface antibodies, which target the surface antigen. And so you can see that when a person with hepatitis B has the core antibody in their bloodstream, it indicates that there's been an immune response and previous or current infection. And when you find the surface antigen in the bloodstream, this is a sign of an active infection. We can go to the next slide. So in this scenario, the woman from the blood bank was actually confirmed to have chronic hepatitis B because she had a core antibody and she had a surface antigen. So the second point we wanted to make this afternoon is that hepatitis B surface antigen rapid tests are very good interventions that should be available in all of your facilities, but there are some limitations. The main one is that sometimes they miss infections. So we did an evaluation of one of these tests called the Determine, which is was under Alere, now Abbott. And the Determine rapid test was found to be 90% sensitive compared to the blood bank type serologic test. So what does this mean? Well, this means that 10% of the time, people who had hepatitis B were falsely shown to be negative on the Determine test. The upside of that, however, is that when we looked at the liver and we looked at the viral levels in these people, they tended to have very inactive infections. And so we concluded that the rapid tests are accurate most of the time. They miss some patients. However, those patients that they do miss tend to have very mild hepatitis B infections. And so it's a good thing that we're not missing patients with very advanced hepatitis B. Next slide, please. So how do you handle discordant results? This happens a lot in the facility where a patient tests positive for hepatitis in one lab and negative in another. So I think for you as health workers, you should try to find out where the test was done. So if the test was done in a central laboratory, such as the blood bank lab, those tests are done under very strict quality and with control measures, and they use very sophisticated machines. And so those type of assays are more reliable than, say, the rapid test. And so it's possible that if the virus infection is very mild, that a person could actually test negative on one rapid test and positive on another. So what we recommend as experts is that if any test comes out reactive, the patient should be linked to treatment and further follow up by a clinician. So it doesn't matter if one is negative or one is positive. If a patient has a positive surface antigen test for hepatitis B, they should be referred for further care, and that should not be ignored. Next slide, please. Okay, what about confirming a positive? So now you've had a positive test. Do you need to confirm the way we do in HIV? With HIV, we always have confirmatory. But the answer in hepatitis B is no. There is no requirement to reconfirm a positive test. So as long as you have tested positive once at any laboratory, you can consider yourself to have hepatitis B infection, and you should undertake further clinical care. And these are the data I'm showing from the World Health Organization, where they reviewed all of the studies on rapid tests. And they showed that the specificity, that is the number of positive tests, which are the number of people at the disease who have a positive test, the specificity is the number of positive of tests over the fraction with the disease is 99% and above. And so essentially, when we see a positive test, there's no need for further confirmation. A patient can be enrolled in care. Next slide, please.
So we have our first poll question. Which of these is true about hepatitis B testing in Zambia? Is it A, the blood bank does not routinely test donors for hepatitis? Or is it B, positive hepatitis B surface antigen tests should be confirmed by a second? Positive hepatitis B surface antigen tests should be confirmed by a second different assay as we do in HIV. Or is it C, a hepatitis B virus prevalence is highest in Luapula, Northern, Northwestern, and Western provinces? Or is it D, a rapid hepatitis B test has a high rate of false positives? So I think if we're paying particular attention to Dr. Mike, he did mention some of the answers. Which of these is true about hepatitis B testing in Zambia? Is it A, the blood bank does not routinely test donors for hepatitis B? Is it B, positive hepatitis B surface antigen tests should be confirmed by a second different assay as we do in HIV? Or is it C, hepatitis B virus prevalence is highest in Luapula, Northern, Northwestern, and Western provinces? Or is it D, a rapid hepatitis B virus test has a high rate of false positives? So we have about 40% participation. I'll allow a few more seconds. Okay, out of 261 participants, we have at least half participating. 10 more seconds. Okay, we can end the poll. So this is how we voted. Majority of us, that's 63%, think C is the answer. A hepatitis B virus prevalence is highest in Luapula, Northern, Northwestern, and Western province. Dr. Mike, would you like to comment on this?
Yes, that is the correct answer. That the HBV prevalence does vary by province, and those are the provinces where we see it the most, according to the data from the blood bank. And I think that I just want to point out that option B, that we should be reconfirming a positive, is incorrect. As I mentioned, if you test positive for hepatitis B surface antigen, that does not require confirmation. And the reason for that is that there are a very low rate of false positives, which was option D. So that's why D is incorrect. I think we can move on now. Great job.
So move on to our second case. In this case, we have a 42-year-old man who is living with HIV and is brought to clinic with his wife because he's acting strangely. She says he thinks he's the president of Zambia, and she also reports that over the past 6 months, he has unintentionally lost weight, but at the same time developed a swollen belly. His ART file was reviewed. HIV diagnosis in 2010 is seen, and he's shown to have started nevirapine, tenofovir, and lamivudine. ART clinical failure with new TB in 2014 was seen, and the patient was switched to lopinavir boosted with ritonavir, zidovudine, and lamivudine. His HIV viral load was undetectable in 2017, 2019, and 2020. And of note, he's had a raised ALT on several occasions. So the table shows his ALT over a period from 2015 to 2020. And you see that his ALT in 2015 was 67, in 2017 was 53, and in 2020 was 87. So he's now tested and found to be hepatitis B surface antigen positive.
Great. So the second population that is the key group to test for hepatitis B is anyone with signs or symptoms of a liver problem. This is a really high priority group to test for hepatitis B. We know very well that the testing kits are sometimes in short supply in facilities. And so therefore we recommend that they be prioritized for those patients who have signs and symptoms. So typically from the outpatient department, perhaps, or from any department where there's evidence that there could be a liver problem. And we did a study here at UTH where we compared the need for treatment of hepatitis B between people who had signs and symptoms of a liver problem, that's the blue box on the right, and those who were tested routinely through antenatal or through VCT or by the blood bank. And you can see that those people who had signs and symptoms of a liver problem, not only were they more likely to test positive, but they were more likely to need immediate treatment. And so again, for the purposes of efficiency in the setting of limited resources and limited testing kits, this is a high priority population, people who have a raised liver enzyme or who have any of the signs and symptoms of liver disease, which we're going to show you right now. Next slide. This is how chronic liver disease may present. So you might recognize a swollen belly, altered mental status, so confusion. So in this case, the gentleman was having delusions that he was the president. So that's obviously signs of altered mental status. Bleeding can occur because the liver plays an important role in clotting blood. Jaundice, which is yellowing of the eyes. And then obviously any sign of liver damage represented by a raised ALT test or a reduced platelet count. Some of you may be aware that a reduced platelet count can occur for various different conditions, but one of them is chronic liver disease. So if a patient has any of these signs or symptoms, we do recommend as part of the evaluation that they have a hepatitis B test. Next slide, please. And then the second teaching point here is around people with HIV, HBV co-infection. So there are, more than 1.1 million people in Zambia with HIV infection, and a good number of them actually have HBV co-infection. I think it could be as many as 8 to 10%, according to the Zamfia survey. And so what is key to know about co-infection is that those individuals must be on a tenofovir-based regimen, meaning that somewhere in their ART regimen, tenofovir must appear because tenofovir is the most potent drug to control HBV. And so even if they don't need tenofovir for their HIV, they would need it for their HBV to prevent them from developing progressive liver disease. So you can see here on this table from, I think, a slightly outdated chart of regimens, that if you look at the second line ART regimens, they typically do not contain tenofovir. They contain lamivudine and various other ARVs, but they usually do not contain tenofovir. And so whenever you are switching a patient or you're prescribing a regimen that does not have tenofovir, you should make sure the person is negative on the hepatitis B test before you do that. Because if you don't, there's a chance that their HIV will remain suppressed, but their HBV will progress, which is what happened in this scenario. In this scenario, it appeared that this gentleman was quite adherent to his ART because his viral load kept coming back undetectable. But since he wasn't on tenofovir, the hepatitis was allowed to progress, and he eventually went on to liver failure and cirrhosis. Next slide, please. And one other point to make is that there is a black box warning around hepatitis B HIV co-infection, which is that when you switch a patient off of tenofovir, they can rarely develop a life-threatening flare of their hepatitis B. So if you have switched a patient recently, and now they're presenting with raised liver enzymes, jaundice, fever, you might suspect, again, hepatitis B as the cause. Next slide, please. And then finally, one question that we are asked a lot as experts in hepatitis B is, what about, how do you add tenofovir to an ART second-line regimen? Because many of you will be aware that we don't find tenofovir as a standalone tablet anymore in our facilities. It's almost universally available, co-formulated with 3TC. So you might find TAF, FTC in your facility, you might find TDF, 3TC. And so if you were to prescribe that on top of a second-line regimen, you would be giving out a double dose of the 3TC, also known as lamivudine. But according to experts, we believe this is safe and is actually much more beneficial for a person with co-infection than not giving tenofovir and allowing the hepatitis to progress. So the answer to the question is you can go ahead with giving a double dose of the 3TC if you must. Okay, back to Dr. Mugala.
So we have our second poll question. Which of these clinical scenarios should prompt hepatitis B PITC, which is provider-initiated testing and counseling? Is it A, pregnant woman with yellow eyes? Is it B, a person with HIV who needs to switch to second-line ART because of virological failure? Is it C, COVID-19 patient with raised ALT? Or is it D, all of the above? Which of these clinical scenarios should prompt hepatitis B PITC, which is provider-initiated testing and counseling? Is it A, a pregnant woman with yellow eyes? Is it B, a person with HIV who needs to switch to second-line ART because of virological failure? Is it C, a COVID-19 patient with raised ALT, or is it D, all of the above? Okay, so we only have 34% participation. What do we think is the answer? I will allow for a few more seconds. Okay, so we can end the poll question. So this is how we voted. Majority of us, 83%, think D is the answer, or the above. Dr. Mike, over to you.
Yes, well done, everyone. So in all three of these scenarios, a hepatitis B test would be a high priority. So in your facility where you might have shortages of the testing kits, these are the type of people that should be prioritized to get access to those testing kits. So a pregnant woman with yellow eyes definitely needs a hepatitis B test. A person from the ART clinic who's being switched on to a second line regimen needs a hepatitis B test. And anyone with a raised ALT, including someone who comes in with COVID-19. Because of course, as you might imagine, just like with diabetes, BP, HIV, COVID-19 outcomes are worse if you have hepatitis B. Next slide, please.
So our third case, this time we have a 31-year-old man with no previous medical problems, and he is engaged to be married. He pays lobola and books for a venue for his wedding. In the weeks leading up to the big event, he develops growing abdominal pain in the right upper quadrant of his abdomen, and the pain is constant and dull in nature and getting worse day by day. He has lost weight such that his wedding suits need to be retailored, and he decides to go for a review. On examination, he has a protruding and hard mass felt in the right upper quadrant, just below the costal margin. He tests HIV negative and the hepatitis B surface antigen positive, and he's diagnosed with hepatocellular carcinoma. He dies within the next 3 months. His family is encouraged to test for HBV, and his mother and 2 sisters are found to be hepatitis B surface antigen positive.
Okay, so the next key population for hepatitis B testing are contacts to an index case. So this case scenario that Dr. Mugala presented is, unfortunately, we do see this commonly. It's very tragic because with early diagnosis and treatment, this cancer of the liver can be prevented. Next slide. So again, we like to infuse local data as much as possible. And so here at UTH, where we have been working in this area for a number of years, we actually did some contact tracing, index testing programs with people living with hepatitis B. And you can see on the right that when you test contacts to people living with hepatitis B, they had about 12% HBsAg positivity compared to about 4% in the general population. So we like to say that the contacts are about 3 times more likely to have hepatitis B infection compared to the general population. Next slide, please. And so one other point we want to drive home is that, like HIV, hepatitis B can be transmitted to sexual partners. However, the virus is a DNA type virus, which is more stable outside of the body than HIV. And so it can spread in other ways. And we generally like to say, rather than just knowing your own status, you need to know your family status, because it spreads to other household members, and it can spread from mom to child. So therefore, brothers and sisters can commonly have the same hepatitis B infection. And so we recommend when a person tests positive that they disclose their status to not only the sexual partners, but people living in their household and their first degree family members. So we want to avoid, creating stigma. And so therefore it's very useful to explain to the patient that this virus spreads in the family. It's not primarily a sexually transmitted infection. However, that's just one way that it can be transmitted. Next slide.
So we have our third poll question. Which is true regarding the strengths and limitation of rapid hepatitis B tests? A limitation is the need to confirm positive results with a central laboratory assay. B, a limitation is that around 10% have false negative results. C, a strength is that the test detects the DNA of the virus. D, a strength is that around 10% have false positive results. Which is true regarding the strength and limitation of rapid hepatitis B tests? I think if we're paying particular attention, Dr. Mike talked about this during his presentation earlier. So we can go ahead and launch the poll. Which of these is true about the strengths and weaknesses of a rapid hepatitis B test? Is it with regards to confirming with a second test? Is it about having false negatives? Is it that it actually does test the DNA of the virus? Or is it that it gives false positive results? What is true about hepatitis B rapid tests? What are the strengths and weaknesses of this test? So we only have about 25% participation. We need to get feedback so that we know that the message is being put across. Please participate in this poll question. I'll allow for a few more seconds. So this is how we voted. About 38% think that the answer is a limitation is that around 10% have false negatives. Dr. Mike?
Yes, that's actually correct. So great job to the 38% of you who voted for option B. So yeah, the main message about rapid tests that we wanted to send is that they miss some patients. Those patients do tend to have milder infections. But if you are really suspecting someone has hepatitis B and they test negative, it is reasonable to try to retest them with another assay. The other answers are not true. There's no need to confirm a positive. So one positive test is all you need to link and treat. The rapid test does not detect the DNA of the virus. It detects the surface antigen, and antigen is a fancy word for protein. So it detects a protein from the virus. And 10% have false positive results is also not true. False positives are very, very rare, which is why if you test positive, you can immediately be enrolled in a treatment program.
So our fourth case scenario is of a 19-year-old female sex worker who has heard about PrEP, which is HIV pre-exposure prophylaxis. And she presents to a Saturday clinic for more information. She reports having multiple sexual partners per week and often does not use a condom. She has no medical problems and takes no medications. She's offered PrEP, which includes a fixed dose of tenofovir and amitriptyline. And as part of her initial enrollment, she's tested for STIs and hepatitis B. Her hepatitis B surface antigen test is positive.
So the last key population we wanted to highlight this afternoon for hepatitis B testing are people who are going on PrEP. Next slide, please. So as I mentioned before, hepatitis B can be spread in various different ways, but high-risk sex is one of those ways. And so people who are being considered for PrEP in your facility, you should also consider them as a key population for hepatitis B testing. But there's a huge synergy here between PrEP and HBV, because when you give PrEP to someone, you're also potentially treating their HBV infection, because again, tenofovir, either the TDF form or the TAF form, are very good treatments for hepatitis B infection. So therefore, since you're doing a synergistic treatment, it's very important that you do know their status, because if you decide to stop a PrEP client's treatment, you could trigger an exacerbation of the hepatitis. Again, I'm alluding to the black box warning, which is in the package insert for the tenofovir medication. Next slide. So if you do find, and I'm sure for those of you who are doing testing, you'll find that about 5 to 10% of your PrEP clients are also HBV positive. So when you do diagnose someone, you should counsel them and of course, discuss index testing. So their partners, their household members, their first degree relatives should also have a hepatitis B test. Because of course, even though they are maybe having high risk sexual contacts, that HBV could have been transmitted to them in any number of ways. So we can't conclude that it was through sex. And then secondly, we recommend as they're going on to PrEP that you also assess the liver. So to assess the liver of a person with HBV, we recommend a full blood count and an ALT. Those are the minimum tests we recommend, because the full blood count gives us the platelet count, which is a marker of liver disease. And the ALT is a sign of inflammation of the liver. So we really appreciate if we can get a full blood count and an ALT test. There's no need to withhold PrEP while you wait for those results. It's just part of the hepatitis B treatment. And then a second part of this is that you can counsel the person that, you know, they're now taking this medication for 2 reasons: for not only PrEP to keep themselves HIV negative, but also has the benefit of treating their hepatitis B. And so we have seen in our clinical practice that this can help motivate the clients to continue their PrEP long-term and not to discontinue it. And so we see this as a huge advantage for diagnosing someone with HBV who's going on PrEP. And finally, if the client does decide to stop PrEP and you're aware of that, you should encourage them to come back to clinic at least for monitoring of their hepatitis B. To monitor the hepatitis B activity, you can follow up with an ALT test. And we recommend, for example, that should be done approximately every 3 months or every 6 months after discontinuing treatment. Next slide. And then we would be, we're focusing on these 4 populations who are high priority for hepatitis B testing. Those are blood donors, people with signs and symptoms, people with HIV who need to go on to second line, and finally PrEP clients. But there are other groups that are recommended by the Ministry of Health. So this would include pregnant women in general because of the issue of mother-to-child transmission, babies who are born to moms with hepatitis B, all healthcare workers should be tested, and people with HIV who were born before the vaccine and might have a high prevalence of co-infection. So there are other populations who are also recommended, but we just wanted to highlight and talk about the top 4 in our minds. Next slide.
So we have our last poll question. Select the true statement regarding overlap in the treatment and prevention of HIV and hepatitis B. A, TLD given to people with HIV does not prevent hepatitis B virus. B, in post-exposure prophylaxis, hepatitis B virus and HIV have the same window periods. C, for approximately 5% of people taking PrEP in Zambia, the drugs are also treating hepatitis B virus infection? Or is it D, in people with hepatitis B virus, treatment is not sufficient to prevent HIV? We can launch the poll. So which of these statements is true regarding the overlap in the treatment and prevention of HIV and hepatitis B? Is it A, TLD given to people with HIV does not prevent hepatitis B virus? Is it B, in post-exposure prophylaxis, hepatitis B virus and HIV have the same window periods? C, for about 5% of people taking PrEP in Zambia, the drugs are also treating hepatitis B virus infection? Or is it D, in people with hepatitis B virus, treatment is not sufficient to prevent HIV? So we only have about a quarter of our network participating in this poll. Please give a go at the question so that we know what to emphasize on even as we open up the discussion. I will allow for 10 more seconds. Okay, we can end the poll. So we have majority of us that think C is the answer. For about 5% of people taking PrEP in Zambia, the drugs are also treating hepatitis B virus infection. Dr. Mike?
Yes, that is the correct answer, C. And so we just want those of you who are involved in PrEP care or who are referring people to PrEP, that you are actually helping us to fight and eliminate hepatitis B. So we thank you for that. And we do recommend, however, if it's possible at your facility, to test people who are going on to PrEP for hepatitis B. You can do it at the beginning. You can even do it during a follow-up visit. You don't have to withhold PrEP for any reason while you're waiting for a hepatitis B test, or if you're getting some other blood tests related to hepatitis B. But we think it's very valuable because you can motivate the client that they're taking those daily medications for now 2 medical reasons. And so that can motivate them to stay adherent and be retained on their PrEP. The other answers are not true. TLD, which is given to, of course, as our first line regimen for HIV, it actually does prevent hepatitis B. So just as PrEP is treating hepatitis B treatment is also PrEP, and actually HIV treatment is hepatitis B PrEP. So I hope you're now confused, but there's so much interaction between HIV and hepatitis B when it comes to treatment. Option B is not true because, in fact, HIV may have a longer window period than hepatitis B. And finally, D is not true because hepatitis B treatment, of course, does prevent HIV acquisition. So now I will hand back to our facilitator. Thank you.
Thank you very much, Dr. Mike and Dr. Mugala, for that wonderful presentation. So before we open up the discussion, we'll relaunch the polls just to see how much our network have been able to grasp. So we have the first poll question. Which of these is true about hepatitis B testing in Zambia? So since we're done with the presentation, I won't allow more time. Which of these is true about hepatitis B testing in Zambia? A, the blood bank does not routinely test donors for hepatitis. B, positive hepatitis B surface antigen tests should be confirmed by a second different assay as we did in HIV. C, a hepatitis B virus prevalence is highest in Wapula, Northern, Northwestern, and Western provinces. Or is it D, a rapid hepatitis B virus test has a high rate of false positives? So 86% of us think C is the answer. And I think Dr. Mike had already alluded to this earlier, so we won't have to discuss that. Our second poll question: which of these clinical scenarios should prompt hepatitis B PITC, which is provider-initiated testing and counseling? Is it A, pregnant woman with yellow eyes, B, a person with HIV who needs to switch to second-line ART because of virological failure, C, COVID-19 patient with a raised ALT, or is it D, all of the above? I'll end the poll. So we have about 96% of us that think D is the answer, all of the above. Dr. Mike, would you like to say anything? No, it's fine. Okay, great. So I
Happy
think
with 95%.
Dr. Mike is happy. I think we're all paying attention. Our third poll: which is true regarding the strengths and limitations of rapid hepatitis B tests? Is it A, a limitation is the need to confirm positive results with a central lab assay? Is it B, a limitation is that around 10% have false negative results? C, a strength is that the test detects the DNA of the virus? Or is it D, a strength is that around 10% have false positive results? So in the interest of time, I'll end the poll. So we have 88% that think B is the answer. A limitation is around 10% false negative results. Are you happy?
Very.
Great. So our last poll question: select the statement, the true statement regarding overlap in the treatment and prevention of HIV and hepatitis B. Is it A, TLD given to people with HIV does not prevent hepatitis B virus? B, in post-exposure prophylaxis, HBV and HIV have the same window periods? C, for approximately 5% of people taking PrEP in Zambia, the drugs are also treating hepatitis B virus infection? Or is it D, in people with hepatitis B virus, treatment is not sufficient to prevent HIV? So about 99% of us think C is the answer, and I think Dr. Mike did talk about this. So I think learning has taken place. Thank you very much, Dr. Mike and Dr. Mugala, for those wonderful presentations. So I'll now open it up to the network for a discussion. I know we have Dr. Agre Mwemba on the network. Dr. Agre, you're welcome. We also have Dr. Hachambwa and Dr. Brighton Sokolo. And right here in the hub, we have Dr. Sinkala to address some of the questions that we have in the chat box. So I'll quickly go through some of these questions. So we have a question from Dr. Daniel Mwamba, who's asking, how do you differentiate between recent chronic and past hepatitis infection, and when do you decide to stop hepatitis treatment? Dr. Nsokolo, would you like to give this question a go? Then Dr.
Okay.
Agba, you can attempt the second question. Then Dr. Hachambwa, you can answer the third question that I'm going to ask. Dr. Nsokolo, over to you.
Thank you, Doc. So firstly, I would want to state that for you to say that this is chronic hepatitis B, one should be hepatitis B surface antigen positive for 6 months, for at least 6 months. So if you've had a patient with a surface antigen positive for that period of time, then you say this is chronic hepatitis B infection. Another way of looking at it is by testing the antibodies against the core antigen. So if somebody has the antibodies against the core antigen, the IgM, then you would consider that to be acute infection. If it's the IgG against the core antigen, which is positive, then you consider that the patient has chronic hepatitis B infection. Then the other aspect of the question is, when do you stop treating hepatitis B infection? So when you are using these drugs that we call directly acting antiretroviral drugs, such as tenofovir, the majority, over 95%, will take medication for the rest of their lives. Will take the medication for the rest of their lives, as long as they qualified at the time they were starting treatment. Now, if, for example, a patient loses the surface antigen, if the surface antigen is lost, you check, you find that the surface antigen is lost, you can actually continue treating the patient and recheck after 6 months. If again the surface antigen is negative, then actually the patient would have lost the surface antigen and you can stop medication. But those are very few patients. Those are very few patients. I think for those with mono-infection, we've seen very few numbers, probably from UTH, maybe I've seen 3 or so patients that have lost the surface antigen. Thank you. I hope that answers the question.
Perhaps Dr. Agre-Mwemba, you can take it up even as you answer the second question. So we do have a comment from Patricia Kasenge, who says, great presentation. Actually, most of our health centers are lacking adequate information on hepatitis B, hence most clients go undiagnosed or mismanaged. My question is it possible for someone who tests hepatitis B surface antigen positive to become negative naturally months later? So I think as Dr. Nsokolo was answering, he did answer your question, Patricia. We do have another comment from Chris Masala. For HIV hepatitis B virus co-infection in a patient with CKD and creatinine clearance of less than 50, what drug can substitute TDF? Dr. Agre-Mwemba, over to you.
Thank you so much. What was the creatinine clearance again? Less than?
Less than 50.
Less than 50.
Yes.
Okay, so for less than 50, obviously, I think that you are looking at our first line being TLD. And now we have TAFAID. So TAFAID should be able to do as much a good suppression of the hepatitis B when you have CKD. And I think that in our guidelines, as long as your EGFR is above 30 mils per minute, square meters, you still can give TAFAID, which is widely available at the moment. And even for those that are less than 30 mils, we still can give TAFAID. We've given TAFAID, but obviously I think that you might need to just consult before you start the TAFAID, as it's not allowed to prescribe below the 30. There are certain circumstances, obviously, that we've still probably prescribed the TLD, depending on what exactly is causing the CKD. So on the large scale, TAFAID. If you don't have TAFAID, we can discuss and see whether TLD, tenofovir itself can still be used. We had discussions previously to look at other medications, but I think that TAFAID is the way to go. Thank you.
Thank you very much, Dr. Agre. So we do have a question from Dr. Manzi coming from Matero Pediatric Center of Excellence. And she's asking, in younger children in whom tenofovir is contraindicated, what drugs do we use to treat symptomatic children with elevated LFTs? Dr. Hachambwa, over to you.
Dr. Mike is actually a pediatrician, so I think he'll give a better answer I can answer one of the other questions, but I'd rather a pediatrician.
Okay.
It's actually both internal medicine and pediatrics. So
Okay, that's fine. You can take on the next question. Dr. Mike,
yeah,
over to you.
I can make it.
No, the answer, thank you, Dr. Chan, but the answer is lamivudine. So lamivudine by itself is available in most health facilities, and that's what we reach to for children who are under the weight or the age threshold for tenofovir. Back to you, Dr.
Thank you very much, Dr. Mike. So we do have a comment from Lea Musole, who says the problem is we've had no hepatitis B surface antigen reagents or strips for a long time now, more than a year. So I think this is to do with programmatic issues. Dr. Sinkala, would you like to address this concern?
Come again, you said what?
We have a comment from Lea Musole, who says the problem is we've had no hepatitis B surface antigen reagents or strips for a long time, more than a year. Lea Musole, would you like to unmute your mic and tell us which facility you're from or which province? Lea Musole? Okay, so it's showing UTH AIDS. So this is Lusaka. So if we're having such challenges in Lusaka, one would only imagine what is happening out there.
Yeah, I think that's true at various health centers, but I don't expect a lot of facilities in Lusaka not to have strips for Hep B testing. Out there might be some hiccups here and there, but one thing we're trying to engage, the MOH to see if we can get more tests or test kits so that we can distribute to various health facilities. We are aware that yes, there are facilities who don't, for some facilities which don't have some test kits. But yes, we have taken note and we will take this to MOH and engage MOH accordingly. Thank you.
Thank you very much, Dr. Sinkala. So Dr. Hachamba, we have a question from Kazungula, and they're saying, for treatment of hepatitis B, what is the drug combination for hepatitis and HIV patients on second line, for example, AZT, 3TC, and DTG? So
Okay,
I think
thank
Dr.
you.
Mike.
Yeah, I think you answered this question actually, but just to recap what you had said earlier. So if AZTs and 3TC combined with lamivudine, you can easily add tenofovir if it's available on its own. But since it's easier to give fixed dose combination, you could give the tenofovir with lamivudine, in which case you'd be double dosing the lamivudine. But Dr. Vinikoor explained that that's fine.
Thank you very much, Dr. Hachamba. So we have another question from Chipatela Brian. How would you manage an infant born from a woman with hepatitis B? Dr. Mike, would you like to go ahead?
Yeah, sure. The priority is to provide an extra dose of vaccine right at the time of birth or as soon as possible thereafter. So those of you who work in pediatrics would be aware that the Pentavalent Vaccine, which is part of the EPI program, that includes a hepatitis B vaccine in it. However, the pentavalent comes in after the baby is 6 weeks of age. And so there's no opportunity to generate an antibodies to protect yourself before 6 weeks. And so therefore, we recommend a standalone additional hepatitis B vaccine dose given to the baby right after birth in those moms. That's really the most available and effective intervention that we have.
Thank you. Dr. Nsokolo, we have another question. So Dr. Manzi is asking if you could clarify on the mode of transmission of hepatitis B virus from an index case to non-sexual household contacts.
Well, thank you very much. So as Mike already put it, I think it's important to also understand that, when it comes to the predominant mode of transmission for hepatitis B, it tends to be sexual and perinatal transmission and transmission during childhood in moderate to high prevalence areas. And then in areas where you have low prevalence, it's mostly sexual transmission. So in our setup where our prevalence is moderate to high, we say that it means that the most prominent mode or the predominant mode of transmission would be perinatal and during childhood. So you know how it is during the perinatal period, you know, there's so much contact of fluids between the baby and the mother. And during childhood, we know that there is so much playing and we have so much contact between kids. So that's why we tend to have high transmission between kids and during the perinatal period. But remember also that if you get infected during childhood or perinatally, chances are very high that that kind of infection will end up being chronic infection. Okay, so over 90% of those who get infected perinatally and during childhood, the infection tends to become chronic. But if you get it during adulthood, which is mostly via sexual transmission, the infection tends to be acute, and within 6 months, the patients tend to lose the surface antigen. I hope that answers the question.
Thank you very much, Dr. Nsokolo. Dr. Mwemba, we have a question which says, how long does the hepatitis B virus survive outside the body? Dr. Agre?
Hi. I think Dr. Mike did allude to this, that the survival for the HIV as compared to Hep B is much shorter than hepatitis. HIV is much shorter than hepatitis B. I can't remember the figures that he mentioned. Mike, would you want to comment on the numbers?
Well, I think that the most cited element is that if blood is on a surface top, such as in a health facility, even a week later, that dried blood can still harbor viable virus. Whereas HIV, the virus denatures very quickly outside the body. Hepatitis B is stronger outside of the human body. And so, so when you're cleaning and you're sanitizing the health facility, when you're using sterile equipment, it's even more important for hepatitis B than HIV because it can linger in the environment longer. So I don't remember a very, very precise figure, but that's the rationale.
Yeah, maybe let me just add. I think it's about, the literature says it's about 7 days, okay? They say about 7 to 10 days, the Hep B virus is able to remain viable on a surface. And so one can actually get infected. Yeah.
Thank you. So we do have another question. So Mr. Conrad says he may have missed it. And he's asking, should treatment be offered to someone with no symptoms and ALT is normal? Dr. Hachamba, would you like to give this question a go?
Yeah, so not everyone who has hepatitis whose test is positive requires treatment. So there are certain criteria that are used, and Dr. Vinikoor went through those that are used. So hepatitis B, I think part of the reason for this presentation is that there are so many tests that are done for hepatitis B, and I know they can be confusing even to physicians, even physicians within internal medicine. So for more specific things, so first of all, to confirm what type of hepatitis they have, chronic, active, and there are different phases. So one interprets all the different tests that are done, the core antibody, surface antibody, e-antigen, and so on and so forth. And there wasn't enough time to go into all those. And then with treatment also, there's criteria for treatment. Not everyone requires treatment right away. As Dr. Nsokolo mentioned, people who get infected with hepatitis B as adults, actually only 5% of them will progress to chronic infection. So one could get away with not treating.
Dr. Loti, Dr. Hachambwa.
So not everyone requires treatment, and there's criteria that are used for treating both acute hepatitis B as well as chronic hepatitis B. I think, yeah,
Thank you very much.
Mike, do you have an additional comment?
No, I think that's right. We don't have universal treatment of hepatitis B. So those people who are found to have an active infection, but it's very mild, we observe. And sometimes at the follow-up visit, then they qualify. So it's not universal treatment. Over.
Yeah, maybe let me just add on that. Yes, we have a criteria, but there are some who you would treat regardless of whether the ALT is raised or the viral load is very high. Patients with cirrhosis. If you find a patient who has cirrhosis and has normal ALT, even the viral load is not that high, that patient does automatically qualify for treatment, regardless of ALT and the viral load. Over.
Dr. Agre, we do have another question, but this time they're talking about a scenario where a patient has hepatitis and HIV co-infection and they have end-stage renal disease and they do not qualify for the TAF. What other treatment options do we have for such a client?
I think I did mention that if one has ESCKD, meaning end-stage kidney disease, and their kidney is not working, we still can use tenofovir in either way, either TAF or TDF itself, depending on the cause. Because if you have ESCKD, it means that there's no need to withhold the drug because the kidney has already failed completely. And so if the kidney has failed completely, we still need to treat the hepatitis B. And therefore, in those circumstances, we might give TAF or we might give tenofovir, TDF. The TDF obviously will have to be adjusted. And the adjustment is such that we might give Truvada or TDF 3TC once per week. And that once per week is good enough to have therapeutic levels for the tenofovir to suppress hepatitis B.
Thank you very much, Dr. Mwemba. Dr. Sinkala, we have a question from Alvin. Is there a plan of making hepatitis B vaccine available in all our various districts for healthcare providers to be getting the jabs against hepatitis?
Well, obviously that's a difficult question for me because I really can't just say yes. But really, the most important thing for vaccination is that first, the key people must be vaccinated. And one of the key, people who need vaccination are people like healthcare workers, nurses, medical students, because these get really exposed to fluid, body fluids, and so on. So these actually need to get vaccinated. Now, we had engaged the government at some level, and they're still advocating for this. And I think in the future, the government is going to avail some vaccine to facilities. Of course, like we've said before, people who need vaccination are babies that are born from, Hep B infected mothers. These actually need vaccine as a birth dose, and then they follow the usual scheduled vaccination. Over.
Thank you, Dr. Sinkala. Dr. Nsokolo, we have a a question from Munyumba Level 1 Hospital. They're saying during the presentation, it was mentioned that a positive hepatitis B surface antigen is equal to infection. What about those vaccinated against hepatitis B virus? Don't they need a confirmatory test?
No, they actually don't need a confirmatory test. As long as the surface antigen is positive, it means that one has active infection. Remember that even if you are vaccinated against hepatitis B, the protection would not be 100%. So there is still that small chance that you can still get hepatitis B infection, but the chance is really minimal. So if the surface antigen is positive, of course, you have to take it that you've got active hepatitis B infection. But if it is the core antibody, it becomes different because then you may have to confirm that there is active infection. Thank you.
Thank you, Dr. Sokolo. So while you're at it, we have a question from Cavaso. You can also answer this question. They're saying, can someone get hepatitis B vaccine if they have a chronic hepatitis B infection or have recovered from past infection?
All right, thank you. So when you have chronic hepatitis B infection, it's not necessary to get the vaccine. Okay, you just need to be on treatment against hepatitis B infection. There's absolutely no need. Then if you recover from hepatitis B, can you get the vaccine? So there, of course, I actually see no harm in getting it, but probably the appropriate way would be to check the level of the surface antigen antibodies. If they are not good enough for prevention, and some people may quote figures such as 10,000 international units per mil. If they are lower than that, you probably may need to take the vaccine as a booster, but otherwise, it offers quite some good protection once you recover from the infection. Thank you.
Thank you. Dr. Mike, we have a question asking, is there any role that abdominal scan can play in the management of hepatitis B?
Yes, so I would say that in some facilities, there's limited access to blood tests, but they do have access to an ultrasound. And so that is a reasonable way to assess the liver once you diagnose someone with hepatitis B. And as Dr. Sankala hinted, it's those people with hepatitis B plus some amount of liver problems that should be treated. Whereas the patients with hepatitis B who have a completely healthy normal liver and normal liver enzymes, we typically wait to start treatment in them. So in that case, the scan can be helpful. The other way is for monitoring or assessment of liver cancer. So if a patient with hepatitis B presents with weight loss and feeling abdominal pain, then those are the symptoms that maybe the hepatitis has now progressed on to cancer. And the first test that we send them for is the abdominal ultrasound. So the abdominal ultrasound test can be very helpful for hepatitis B. Over.
Okay, so while you're talking about HCC, we have a question from Odon. If the patient has developed hepatocellular carcinoma due to hepatitis B virus, are we supposed to continue with treatment? And if yes, why? Thank
you. Yeah, that's a great question. So the mortality from hepatocellular carcinoma approaches 100% in our experience. And unfortunately, the life expectancy is usually several months or even 6 months, but it usually doesn't go beyond that. The literature does indicate that there seems to be a slightly longer survival if you continue the treatment than if you stop it, probably because the virus is under control and it might relieve the inflammation related to the cancer. We usually leave it up to the treating clinician's discretion. At that point, the focus is usually palliative care. And so with palliative care, you really want to focus on managing pain and suffering And if the patient cannot be swallowing that medicine for hepatitis B, we don't really put a lot of emphasis on it, but certainly it can be continued in that setting. Thank you.
Thank you. Dr. Nsokolo, we have a question. Since we are including hepatitis B vaccination in our children's schedule, does it mean that if they get infected with hepatitis, the vaccine did not help for it to progress to chronic hepatitis B? We have a question from Mrs. Chisanga.
Okay, thank you very much. So if you noticed from Mike's presentation, there was a statement to say that all those are HIV positive and, or should I say all those born before 2005 when the vaccine was introduced also need to be tested. So what it is that as it is now, the prevalence is even low because of that vaccination. But as I mentioned earlier, the thing is that even with vaccination, there still remains a small chance that one could actually get infected, but the chances are really slim. So a few of those that are vaccinated during childhood may still get hepatitis B infection, but chances are quite slim, and they may progress to chronic infection. So those other preventive measures, of course, need to be taken into consideration, though we don't usually pay that much attention during childhood, that body fluids, contact with body fluids and so forth. But still, if one gets it, I mean, if one is one of those unfortunate ones, they may actually get the infection and progress, but that's a very slim chance. Thank you.
Thank you.
So maybe just to add on, so I think Dr. Mike had mentioned that in our program in Zambia, vaccination is done at 6 weeks. And not all pregnant women at the time of delivery have a non-hepatitis B self-certification status. So there could be some who are positive for hepatitis B and they give birth, and no one knows that the baby is supposed to get a dose at that point. So all those are potential areas where babies could still get infected even in this day and age. Over.
Thank you, Dr. Achamba. Maybe let me just add on. Thank you for bringing up that point. That's really true. That's why if you check, WHO recommends that within 24 hours, as soon as possible, you actually give the vaccine to a baby that is born to a mother that is hepatitis B surface antigen positive. Also take note that if the mother is E antigen positive, it even makes the situation worse, and you may even have to consider giving the child immunoglobulins because chances are much more increased when the mother is E antigen positive, most likely with a very high viral load. So that window, because of the way our vaccination is, allows for some children to actually end up having hepatitis B infection. So that's one of the points that we probably need to help in terms of policy, so that the first dose can be given as soon as possible rather than waiting for the 6 weeks. Thank you.
Dr. Sinkala, we keep seeing a question in the chat about when to stop treatment. So we have a question from Chris and Matthew. So maybe you could just repeat what you said, just for the sake of emphasis. When do we decide to stop treatment for hepatitis?
Okay, thank you very much. I think Dr. Nsokolo mentioned this, but I think we can still emphasize on this. So normally when you start hepatitis B treatment, very few people do actually get rid of the virus. Okay, so seroconversion of HEPs, the surface antigen to negativity is about 1 to 2% per year, which is very, very low. And therefore, when you're treating a patient, just tell these patients that they're going to be treated for the rest of their lives. I think that's a message. But in the event that they clear the surface antigen, you could stop, but you don't stop immediately. You may want to continue Tenochobar for the next 6 months or 1 year. And if they remain negative, then you can consider stopping. Even when you stop, remember that you must keep on testing them so that you are sure that they are cured. Now, there's one group that you really, even if they clear the virus, you might not even consider stopping. And these are patients who have cirrhosis due to Hep B. Those, once they start medication, they will be on medication for the rest of their lives. You don't stop medication in a cirrhotic patient due to Hep B. So you have to continue for the rest of their life. Over. I hope now this is well grasped.
I think it's clear. Dr. Mike, we have a question about the mode of action for Tenochobar and hepatitis B infection, bearing in mind that hepatitis is DNA and like HIV, which is RNA.
Yeah, so it blocks the reverse transcription from RNA to DNA inside of the cytoplasm of the cell. So essentially, I showed one figure of the hepatitis B virus life cycle. And so what I was hoping that some of you would pick up on is that the virus does two things. First, it makes daughter viruses, and that is the step blocked by tenofovir. But then it also makes the surface antigen. So when you understand this, that there are two pathways, you'll understand why a person can be very adherent to their hepatitis B treatment, but the surface antigen is still there in their bloodstream. They keep testing positive. So they get frustrated. They say, why am I still positive? Well, they're positive because the virus is still producing the surface antigen. However, the benefits are that the new viruses are not infecting the liver, and the actual damages to the liver, which are caused by the viruses, have receded. So further, that person is not infectious. Just like in HIV, where we say treatment is prevention, right? In hepatitis B, treatment is also prevention because you're actually reducing the transcription of the virus to making daughter viruses. So tenofovir is actually a very potent inhibitor of that step of the viral life cycle. And actually, one benefit of tenofovir we haven't even talked about today is that there is no resistance. So for some reason, the hepatitis B virus has not learned to develop resistance to tenofovir. So some of the things we really worry about in HIV around resistance are a non-issue in hepatitis B. So that was a great question. Thank you.
Thank you very much, Dr. Mike. So we have one last question from Mwenya Brian, a midwife from Maramba in Livingston. And he's asking, what do the national guidelines say about assisting a woman positive to hepatitis and in labor? Should the midwife be given prophylaxis for hepatitis B?
Oh, we want to take that.
Dr. Sankala?
Right. I mean, first of all, a midwife is a health worker. And we keep emphasizing, all health workers need to be vaccinated against Hep B. It's a must. Like those that even work in labor ward, you must get vaccinated against Hep B. And the vaccine is not that expensive. All nurses, they can easily afford this. Secondly, if a midwife is delivering a Hep B positive patient, all you need is just to get gloves. You don't necessarily need to be exposed unnecessarily. So you don't need treatment to prevent you from that. It's just like any other health worker, like you're handling a patient who's positive for Hep B, you just need to get precautionary measures such as gloving and so on. Yeah, but most importantly, I think all health workers, midwives included, all nurses must be vaccinated against Hep B. That is a very good protective measure. And then add on other precautionary measures like gloving and things like that. Thank you.
So in that vein,
I can just add on briefly. I just wanted to make sure that there's no misconceptions. This virus, although it's more stable out of the body, it doesn't spread through casual contact. Yeah. You have to be exposed to the blood or body fluids of someone with hepatitis B. So handshaking, casual contact, hugging, there's no transmission. And so health workers should not be afraid to take care of people with hepatitis B because if we are perpetuating stigma, that's going to cause a lot of challenges in getting people diagnosed and treated. So, and so really standard precautions work. And on top of that, I just want to say, if you're a health worker and you have been exposed to a needle or blood or body fluids from a patient with hepatitis, we also have PEP, post-exposure prophylaxis, which follows very closely on to what we do for HIV. So there are plenty of ways to protect yourself as a health worker. I'll stop there, thanks.
So in line with vaccination, we have Mr. John Kaluba, who's asking how we can engage the Ministry of Health to have NEMA to cover vaccination for all our healthcare workers. Is that possible, Dr. Sinkala?
Well, yeah, it's a good idea actually, because NEMA is here to help all of us. And it's one thing that we can sell to MOH and see if they can cover that, that aspect. I mean, that's a good thought. I think we will take it up and present it to the higher authorities to see if they can consider it. Thanks.
Thank you. So we've had a very fruitful discussion today, but in the interest of time, we'll have to wind up. Dr. Hachambwa has, I think, dropped off. We'd like to thank you very much, Dr. Hachambwa, Dr. Nsokolo, Dr. Agre Mwemba, our didactic presenter, Dr. Mike, Dr. Mugala, Dr. Sinkala, Kunda, who helped us with coordination, Mr. Chatonda and Kote, who assisted us with IT, and the rest of the network would all like to thank you for your participation in making today's session a success. We'll be having our session next week on advanced HIV, and we'll be reaching out to some of you to submit cases for discussion. For those that haven't registered, kindly use the link in the chat box to register your attendance. From the hepatitis team, would like to say thank you to you all for logging in and have a fruitful week.